terms of explaining aerosol transmission to someone. And hopefully there's been a somewhat better increase, somewhat of an increase in your ability.
See, you're a real good teacher, Lisa.
Well, at least I moved them up from the very uncomfortable and somewhat uncomfortable to the somewhat comfortable and very comfortable, and that's good. For such a short period of time and a short description, that's not bad. And so hopefully, you know, as time goes on, you'll have a chance to read a little more about this, think more about it, and have this effort to explain this to people. So thank you. So moving on, I'm going to talk next about person-to-person transmission, and you know that is one thing we know pretty for sure, and that's in CDC guidelines right up at the top. How does COVID-19 spread person to person? But what does that mean? Well, what we see is clusters of people, and almost all of them have been indoors. Family in China, there was a lot of transmission in families, especially after they locked down, and that's happened in the U.S. and around the world as well. Indoors, restaurants and bars, especially recently, and of course in lots of workplaces, and that's of course where I'm most concerned about and what we're talking about today. What we also see is a lot of transmission that's happening from people who don't have symptoms, as I mentioned. And the talking and singing, and that's, you know, the choirs in the churches, that also seems to add to the risk. And that's not surprising if you think about human-generated aerosols, and what I showed is the large concentrations that people generate when they talk and singing is like talking, only louder, so you just get more aerosols. So the risk factors, if I had to put them down, are indoors, enclosed spaces, low ventilation, and that's true in many places like restaurants and bars, a lot of people spending a long time together, and people in close proximity to each other. So we're going to talk a little bit more about those, and I just, you know, have some pictures of people in what seem to be some of the highest risk. I've been keeping track of clusters in workplaces since the beginning. Corrections officers, checkout people, warehouse workers, obviously healthcare workers, you know, assembly line workers. So, and these are just a few of the very many people who experience at work significant transmission, infection, and unfortunately death. I'm going to just illustrate the way I like to think about transmission is from the perspective of source to pathway to receptor, and I'm going to take the call center as a good example just to illustrate this. So hopefully my animation is going to work. So if you take one person who's their source, of course we don't know who that could be, but it could be anyone, it could be more than one person. But for purposes of this, one person, they generate aerosols by talking, and call center people spend most of their working times talking on the phone, and so that aerosol, those aerosol particles are generated and eventually distributed all the way through the room, depending of course on the ventilation. And if someone else is talking and generating infectious aerosols, they simply add to the viral load, so to speak, in the room. And eventually, as you can see, if it's distributed, it could be, certainly the person sitting nearby has probably the highest risk because the higher concentrations occur there. But people further away are also at risk. And when you look at clusters and the epidemiology, you do see that the people closer are at higher risk and more likely to be infected, but that you will get infection at some distance away as well. And it's well beyond the 6 feet that we talk about. And this is simply because aerosol particles, smaller ones in particular, are easily distributed throughout the room by diffusion and by air currents. So in the context of thinking about controls, and I'm leading up to the last section where we're going to talk about control banding, where you we're going to talk about more how do we actually identify risk for workers and maybe select controls that are appropriate. But I'm going to talk about controls, and this is like the hierarchy of controls, but thinking about it in this source pathway receptor perspective. Source controls, for example, would be, well, of course, if we could remove the sources, and anyone, of course, can be a source, and remote work, for example, and that's what many places have done and continued to do, and that's pretty much what I'm doing, is working from home. We could, if we had good testing and contact tracing and other methods, we could screen and test people to identify who might be infectious, and then exclude them from the workplace. Unfortunately, that isn't guaranteed to work if there are people who do not have symptoms. So that's proven to be less useful than we'd hoped. And you could also adjust work schedules to simply limit the number of people in space or the amount of time that they spend in that space. So the principles are anybody can be, workers or customers can be infectious. So you want to eliminate the sources if possible, or decrease the number of them, or use other methods to come up to actually accomplish your tasks by changing the job or maybe isolating those sources. And isolation is working from home, basically. If we think about pathway controls, these are basically trying to break the link between a source and a receptor. And so one of the things that has been proposed in lots of workplaces is to put up barriers. The problem I see with barriers is that there's really no evaluation of their effectiveness or impact with respect to limiting small particle transmission. Barriers are proposed because it's thought that they will break the transmission of droplet propulsion, which they likely will. But there are, as we mentioned, these smaller particles that you generate talking, whatever, breathing, that can be distributed. And it may be that these barriers even in some way impact the ability for the ventilation to do its job. And so you can't just assume that you put barriers in place, you've stopped all aerosol transmission. And I've been encouraging industrial hygienists and health and safety people to think of ways to evaluate the impact of a barrier. We could increase the amount of dilution air, and that's been proposed by ASHRAE. So simply increasing the number of air changes per hour lowers the concentration overall in the room, removes particles more quickly, and ensures a lower concentration and a lower risk of breathing in infectious organisms. You could separate clean and dirty sites. This gets done in healthcare settings. You could use distancing, but you have to remember that distancing may work for those larger droplets, but might not work for small particles, especially the ones that basically are distributed by diffusion throughout the space. We could use local exhaust ventilation in industrial settings. That's a lot of what we do, is use local exhaust ventilation for hazardous aerosols. And we haven't really come up with a perfect way to do this for individual people, although there's some discussion of personal ventilation in office spaces. And I won't be surprised if we see some more development of that, but I've been recommending high efficiency portable air cleaners, and I've got a picture of one of those, as a way to, and you could use those somewhat as local exhaust ventilation, as well as a way to increase the air changes per hour in a space, just by basically cleaning the air and moving more air around in a particular space if you can't increase ventilation. And you may need a combination of these, and as I already probably illustrated, it's a little more complex than simply putting up a barrier or cleaning a surface for contact transmission. So the principles are obviously to break that pathway, thinking about anyone can be a source and anybody can be a receptor. These are more complicated, they may require some expertise. And I also want to say, when you add pathway controls, you may be adding additional hazards to the workplace. And a good example is in meatpacking, where people are already working very close together. A lot of ergonomic issues. You add barriers, you may make their job even more complicated. It may impact communication, so you have to think about the additional hazards. So the purpose of the hierarchy of controls is to focus on those first two kinds of measures, the source controls and the pathway controls, but at the end of the day, it may be, and in healthcare, this is that's a good example where you pretty much may have to rely on some kind of a personal protective equipment. Or I also put in isolating the people, the receptor, so to speak. So if you knew that you had people who were not infected, you could cohort people to have some control over their infections or their likelihood of being infected. But I put control rooms and cabs, ventilated cabs here as a possibility as receptor controls, where basically you're separating the person from anything else, from any other possibility of being exposed to a source. But many times what we think of as receptor controls are personal protective equipment. In the context of aerosols, the only appropriate personal protective equipment in terms of inhalation is a respirator. And I'll talk briefly. Face coverings and surgical masks are not respirators. They're not personal protective equipment. So, and why do we put those last? We put them last because they require more more participation from the employee. In the case of a personal protective equipment, they have to put them on. They have to put them on correctly. They have to stay in an enclosed space. And PPE requires all sorts of things like good fitting and maintenance and training. So in source and pathway controls, you're basically engineering out the hazard or the exposure. In receptor controls, you're not. And it's a harder thing to do correctly. I will briefly talk about masks and respirators. And I did write an article for the University of Minnesota Center for Infectious Disease Research and Policy, CIDRAP, which I do recommend reading. That talks about the key things related to face coverings, masks, and respirators. And these three things are really key, and they need to be considered in this order. You need to understand how efficient is the filter, how well does the face piece prevent the inward leakage of particles, meaning how well does it fit, and then finally, is it put on properly and each time that you wear it, and is it worn properly? I'm not going to go through a lot of the preliminary information that leads to my conclusions, but I am going to give you my conclusions from that article. And face coverings, basically, the filters are extremely inefficient. And it is true, you can build up layers and layers, but what you will discover, of course, is the more layers you add to a face covering, usually made out of some material, some cloth material, is they become harder and harder to breathe through. And so the breathing resistance makes it impossible to wear something that is efficient or find something that is efficient, even a surgical mask or a respirator. Fit factors, if I were to measure a fit factor for a face covering, as we do for respirators, you might get a fit factor of about 2 if you're lucky. And that's about 50% reduction. Now that sounds like a lot, but in the context of particles in air, breathing them in, and what we think we know about the infectious dose, it doesn't take very long for someone to get an infectious dose if they're wearing a face covering. And it may be that we don't know how much face coverings limit or prevent outward leakage, but it is probably more leakage outward than inward. And that is because you get a lot of leakage all the way around the face piece when you're breathing outward. And the physics of that, I don't have time to explain, but unfortunately we haven't measured what I'm calling total outward leakage of face coverings or surgical masks. So I can't give you a number. I can simply tell you it's probably quite a lot. Now it's true they will capture some of those larger particles and droplets. So I do say they may be possible as source control, but they are not personal protective equipment. So if you knew for sure who's infectious, you could give everyone a face covering, but at the same time, if you're worried about breathing in and being infected, that face covering isn't going to do much good for you. Surgical masks are a little bit more efficient in their in their filters. Unfortunately, the range is very wide, and I've tested surgical mask filter penetration, and it's all over the map. They also do not fit very well. They may be able to get a fit factor a little bit better than a face covering 4 to 6 if they have good filters. And I mean that because filter efficiency is important before you do fit. So if they have good filters, you might get, say, a fit factor of 4 to 6, which means maybe about 60–70% efficiency. That's meaning breathing inward. We, again, do not know how well they manage or prevent particles from being emitted outward, and except we do suspect they will do well for larger droplets, again, as source control. Respirators, of course, the filters are very efficient. They're designed to be so. It is evaluated on each person, and you have to be, with a half-face piece respirator, have to achieve a fit factor of at least 100 to be able to wear it in the workplace. You know, that's a very high efficiency. Again, we do not know much about total outward leakage, but I would say that it's probably much less than you would find with a face covering or a surgical mask if it's a well-fitted respirator. And so these are good both for source control and for personal protective equipment. And fit testing is important.